Good evening, everyone. We'll give it a moment for everyone to make their way in. We have such a great presentation tonight. I am super excited. Something different. This is going to be a very unique presentation and a first time Wu Yu presenter, which is always exciting. So, welcome to tonight's Wu University event. You're seeing 2020, What's Wrong? The Psychology Behind Vision Improvement. Thank you. I'm your host, Dr. Jennifer Stewart. And thank you to Glaukos for supporting this event with an unrestricted educational grant. Please take a moment. There's going to be a poll that pops up on your screen. So just take a moment and answer those few questions for us, please, before we move along. It's very important, helps us collect information. There will also be a poll at the end, so keep an eye out for that. I'll just give it a second before we move along. Make sure everyone got the poll. Okay. So just some housekeeping before we continue. For each hour of CE, attendees must be online for a minimum of 50 minutes. For a COPE certificate, please fill out the survey link in the chat. The survey link will also appear when the webinar ends. CE certificates will be delivered by email and sent to ARVO with OE tracker numbers. We'll also display a QR code at the end of the event if you have the OE tracker app on your phone. CE certificates will be emailed within 4 weeks, and make sure to ask questions throughout the presentation using the Zoom on-screen floating panels. If you're on a mobile device, you can use Q&A or chat at the bottom. So it is my pleasure to welcome first-time Wu Yu presenter, right? Yay! Welcome to Wu Yu. Dr. Kriti Bhagat is a graduate of the Pennsylvania College of Optometry at Salus University and completed a cornea and contact lens residency at Salus University. She's the owner and founder of Ideology Vision, a cold start private practice concentrating on cornea and specialty contact lenses. She's an adjunct professor at Salus University, a continuing education speaker, and in her spare time, she's a book editor for publishing houses and knows every book known to man. So there you go. She is, if you need a book recommendation, she's your person. Welcome to Wu Yu. We are so excited to have you.
Thank you. And I'm humbled and honored to be here and also to be introduced by you. So thank you so much. These are my financial disclosures here. Again, thank you so much for everyone for not only inviting me, but spending your time, which is very valuable, with me today. Today's topic is something that's definitely dear to my heart. I see many keratoconus patients, as I'm sure many of you do also, but kind of looking at it from a different perspective. This is something I've learned in the 10 years of practice, and I will say when you have a patient that is keratoconic and you are able to help them, whether it's with glasses or with specialty lenses, and they're seeing so much better, I always expected them to jump out of the seat and just to be like, oh my gosh, thank you. Wow. Right. And so I have learned through the years that it's not always the reaction that they have. So you're seeing 2020, what's wrong? And that's usually the kind of the reaction that I have in my head. And so it's been a while since I've kind of learned about this. So I want to share with you the psychology that comes behind vision improvement in keratoconus patients and why they react or what they experience and how we can help them with that. So again, my disclosures here. And let's start off with talking a little bit about keratoconus. So this is just like kind of introduction stuff. The first report of keratoconus was in 1736. Benedict Duddell really described cornea as prolapse corneae, corneae cornica, sugarloaf cornea, precedentia cornea. Those are all things that we may have read in some research articles, right? The modern definition is more of keratoconus is a chronic progressive corneal ectatic disorder characterized by a conical protrusion of the cornea, thinning of the stroma, and irregular astigmatism. Now, how is keratoconus different? How is keratoconus different than some of the other diagnoses that we kind of come across with our patients? It's a chronic diagnosis that happens at a young age. That's the main key factor here, is compared to other chronic diseases that we manage like cataracts, glaucoma, macular degeneration, keratoconus happens at a young age. this is sometimes happening, and we're discussing this before patients even have a coping mechanism that they've encountered, right? So when you talk to some of our patients that may be older, they know that their knees are going to start hurting or their back will hurt, arthritis. They expect these things. Young patients do not expect to be diagnosed with a chronic diagnosis. Second, there's a threat to having vision loss or blindness. Again, there's this unknown fear that it may progress, it may not. What is the extent of vision loss that they're going to experience? And also, there's a lifelong management piece here. So keratoconus is different because it's not something that, hey, these are glasses and you can have them, you're going to be able to see. Great, I'll see you back in a year. There's a lifelong management piece to it, and it's not always a simple treatment plan. There's long-term care, there's follow-ups, there may be multiple treatments that we're talking to our patients about. And so that's how keratoconus is different than some of the other diagnoses that we talk to our patients about. In the past, the treatment of keratoconus may have been very simple, right? I put it as simple. You avoid eye rubbing, you correct them with either glasses or contact lenses, and then if they need anything more, it's generally a full thickness corneal transplant. Modern treatment of keratoconus has changed. With corneal collagen cross-linking available, we can now treat our patients to help slow or halt the progression of the disease. There are new advancements that are being looked into to maybe help patients with thinner corneas, maybe incorporating contact lens into the surgery, or even accelerated treatment. Remember, there is one FDA approved corneal cross-linking treatment for our patients, and that is more of a modern approach to keratoconus. Specialty contact lenses. We've had so many advances in that. Scleral lenses, hybrid lenses, newer materials, designs, oblate, prolate designs. I could keep going on, and especially with higher order aberration corrections. We have options for our patients. And then finally, even advances in the corneal transplant world. We have different transplants that expose the eye less and are quicker also, such as deep anterior lamellar keratoplasty, Bowman's layer transplantations, and other advancements. Let's take a look at some of our benefits. So from a cross-linking perspective, you have lifelong savings. So some of these studies, I have listed all of them on the bottom, references. So in case you do want to look up the study or read more, just like I do, you can. So when you look at cross-linking versus conventional methods of treatment, the cross-linking group in the study was found that 25.9% less likely to undergo penetrating keratoplasty. These patients also spent almost 28 years fewer years in advanced stages. This group of patients, the cross-linking group of patients, had a lower total direct medical cost. You can see the difference between about $31,000 versus $39,600. And also over the span of a lifetime, their cost savings was about $44,000 per patient. So not only are you presenting them with an option that can slow or halt the progression, but also helps them financially. When it comes to cross-linking, some of the doctors in the study, you'll hear like from an anecdotal part of it, that they really like the referrals from optometrists because optometrists really are kind of thinking about the patient as a whole. How safe is this, right? You're recommending your patient for a surgery. And so we're thinking safety perspective. And from a safety perspective, you can see here that less than 2% of the patients had infiltrates or persistent epi defects after cross-linking. So it's a safe procedure. Let's talk about scleral lenses. Scleral lenses have made a big impact on the world of keratoconus and our management. There are many benefits of scleral lenses, but from this perspective of this study, you can see it improved visual acuity, improved quality of life using the NEI questionnaire. You can see also from the Eye Bank Association of America, they release statistics every year. And what they've found over the past few years is that there is a decreasing trend of keratoplasty procedures for keratoconus patients. And they really attribute that to newer RGP scleral contact lenses. So it's a big impact that we've made. Oh, this is a little bit about keratoconus evaluation, right? We're familiar with this. What are we looking for? When we're looking at our patients, we're looking at symptoms, history, family history. We're doing autorefraction, keratometry, visual acuity, and signs. Then when it comes to testing, there are many things we do, but in general, some of the advanced testing we're doing is topography, tomography, anterior segment OCT, right? A lot of times what I've found is that when I'm doing this testing, I'm looking at all the details of the eyes, but what I'm forgetting to look at is the big picture around that. So I will tell you this. For me, I love my Pentacam. I absolutely love it because we get patients who are referred to the office. And so we do the Pentacam. And while the technicians are still working up the patients, I'm running to the Pentacam to see, all right, is this patient keratoconic or not? This is something I used to do a lot in the beginning when I first started practicing because I was seeing a lot of keratoconus patients. I get so excited. I'm excited. Yes, I'm going to go in there and change this person's life, right? What do we normally do? What I normally do is look at the pentagram and run into the room, and I'm excited to give them all these options that they have. And here's where I want to stop us or someone like me, right? Stop. What we should be reviewing before we're going into the room is also review of systems and understanding some of the correlations that the review of systems can have on how we present the diagnosis to the patient. So when it comes to the review of systems, you can see kind of on the bottom left side of your screen, usually we just ask 2 questions on the psychiatric review of systems part. Anxiety/depression, other. We're not really looking into anything else, right? And when we look at that, what are we truly interpreting? What we should be looking at is a little bit more in depth. We should be looking at depression and other mood disorders, personality disorders, substance abuse disorders, anxiety disorders, somatization disorder, eating disorder, cognitive disorder, and psychotic disorders. Okay. When you look into that, let's look at this definition of mental health. Mental health is a state of mental well-being that enables people to cope with the stresses of life, realize their abilities, learn well and work well, and contribute to their community. So any of these things can affect that, right? Mental stress, there's a lot of mental stress that's behind becoming blind in general. Take keratoconus out of it, but just getting news that you could be going blind. There is loss of vision. You're receiving this grim diagnosis that might not have a good prognosis. Patients tend to experience worries, anxiety, fear, depression, and start having social isolation. About 1/3 of people with vision impairment experience subthreshold depression and or anxiety. And when it comes to interventions, interventions are less effective on patients that are elderly, that have kind of more of a increasing psychological well-being. There's less interventions that we can help with. Definition of depression. Depression is a medical illness that negatively affects how you feel, the way you think, and how you act. So think of that correlating with vision impairment. Vision impairment and depression have a direct correlation. Vision impairment can lead to disability. This can also lead to depression and a decreased motivation/determination. Vision loss is associated with mental fatigue, less social contact, can induce feelings of loneliness and social isolation. So when it comes to trials have shown that problem-solving interventions can actually help improve vision-related functioning and emotional distress. When you look at some of the interventions that can help with patients, you look at some things that even from us when we talk about what recommendations we can make for our patients, it can be group therapy, art therapy, animal therapy, counseling, and wait, vision therapy, right? So these are some things that can help with our patients understanding their vision impairment. Anxiety. Anxiety is an emotion characterized by feelings of tension, worried thoughts, and physical changes like increased blood pressure. When it comes to anxiety, patients with vision impairments are 7.5% more likely to have anxiety disorders, especially agoraphobia and social phobia, than peers that are normally sighted. So you think about when patients start experiencing vision impairment, you have to start thinking that they're experiencing anxiety, fear. All of us have fear, right? Fear is a basic, intense emotion aroused by the detection of an imminent threat involved in an immediate alarm reaction that mobilizes the organism or the person, right, by triggering a set of psychological changes. This is the initial reaction that many, many patients have when they're diagnosed with keratoconus. You see it, you can see it in their face, and it's a physical reaction they have. And so for me, it's always interesting because when I've read this study, you start thinking about 7 stages of grief, right? How many times have you had a patient that you're seeing for keratoconus? They were diagnosed maybe from somewhere else. And I feel like I've had this few times where they're already in that phase of pain and guilt or even anger. So they've had the shock, they're in denial. I don't have keratoconus. I'm here so you can help me fix my eyes, right? There's that anger. You can feel the pain and hear it in their voice. They kind of go through that. Then they also start going through this phase where they ask you, well, did I do something? What did I do? How can we fix this? What can I do? Can I go back in time, right? Then I've had patients who are also very, very quiet. They go through this depressive manner. And usually I want to say that we're able to help our patients with that upward turn. Let's lay out some of the treatment options, right? When you talk to them, or you put that specialty contact lens and they can now see after not being able to see, reconstructing that, working through it. And then when they come to the acceptance and there's hope. So the 7 stages of grief, I feel like I can really truly see it with some of our patients that we've managed. So, mental health impact on keratoconus. This was a literature review of 31 articles. It focused on the negative effect on mental health or emotional well being of keratoconus patients. There were various questionnaires that were used throughout all the different articles. The most common was the NEI Visual Function Questionnaire. These were also studies that were from all different countries, so that was interesting to see. The results were that there were worse health scores with lower visual acuity in the better eye. So, patients who had a lower visual acuity, the lower it was, the worse their health scores were. This also included patients who had increasing ocular asymmetry, corneal curvature, and worsening disease severity. This was an interesting part for me that like really kind of popped out. Asian countries had little to no correlation, while most of the other countries had a strong correlation. There was also a discussion part to it, and it makes me think about this too, that Asian countries also have a different perspective on mental health. Do we talk about it? Are there therapists? Is that kind of pushed upon more so than some of the other countries that were there? So it was an interesting discussion point to it. When compared to macular degeneration, diabetic edema, macular edema, RVO patients, keratoconus patients had the highest mean visual acuity, but the worst quality of life and emotional well being scores. So it doesn't always have to do with how bad is your vision. That doesn't correlate. And you can see that here. Lower scores were in patients with progressive status versus stable status, and patients with keratoconus had more dysfunctional coping mechanisms. Here's an interesting thought process also. Does vision loss cause stress, or does stress cause vision loss? I feel like we've talked about this topic throughout different types of diagnosis. And so let's take a look at it from maybe a keratoconus part of it. So, mental stress has been correlated to vision and has been correlated even in transcripts from 3,000 years ago. In a transcript that was from 3,000 years ago, you can see here, there were 18 causes of vision loss, and 6 of them had to do with signs of bodily or emotional stress. The psychological or physiological response to an internal and external stressor, right? Stress involves changes affecting almost every part of your body, especially the nervous system. And we've seen that with studies out there with glaucoma, optic neuropathy, diabetic retinopathy, retinitis pigmentosa, and macular degeneration. So when you look at it from this study's perspective, stress and inflammation, immune cell activates, there's increased nuclear factor kappa B production. This causes a secretion of inflammatory mediators. These inflammatory mediators increase TNF alpha and interleukin 6. Now you have stress hormones that are in your vascular system. There's a decrease in nitric oxide production. This can lead to vascular deregulation, leading to insufficient oxygen supply, and you have endothelial cell loss. Tell me which cells are affected in keratoconus, right? So kind of interesting and a topic to be discussed where stress can correlate with this, with keratoconus. Can it? There's research, there are articles that are out there. So it's kind of an interesting point to it, especially when we're looking at it from a mental health perspective. So that was the diagnosis. Now, what about presenting the treatment options? What do you normally do? I think you guys kind of have figured out me out a little bit. I run into the room. I'm running into the room to tell this patient how I can help them and how I can, maybe fix their vision. This is where I say again, stop, right? We should be reviewing patients' personality traits, maybe understanding how they may interpret these options. Maybe it's a little too much for them. How does it change the way you present your treatment options? So, personality traits. Let's talk about that. a relatively stable, consistent, and enduring internal characteristic that is inferred from a pattern of behaviors, attitudes, feelings, and habits in the individual. There have been studies and articles written for a while now about the keratoconus personality trait, right? Keratoconus patients have sometimes, unfortunately, been called to have an odd mentality, compulsive scratching mentality, emotional crises and upsets. They're unusual patients, paranoid, bizarre, untrusting. When the CLEC study was done, they also studied the quality of life of keratoconus patients, and they found that patients with keratoconus have a similar moderate to severe quality of life as macular degeneration patients. There have also been articles that have been written to describe patients with keratoconus to have psychoasthenia and even correlation to schizophrenia. Now, this study here looked at personality traits. There are two major personality questionnaires. First, the Million Index of Personality Styles. What this found was that keratoconus patients are more pessimistic with increased imaginative intuition, social withdrawal, insecurity, and anxious hesitation. They found that it was improved, these traits were improved with successful contact lens wear. The physician attitudinal studies found that it characterized actually keratoconus patients as being less confident, poorly adjusted personalities, less friendly, less insightful, less self-controlled, and more emotionally labile. In a case control study with 60 subjects, with 30 with keratoconus and 30 with healthy subjects, what they found when they assessed the quality of life was that their temperament, when they evaluated the temperament and their psych evaluation, they found that keratoconus patients are more prone to mood and anxiety disorders than non-keratoconus patients. 88.9% of keratoconus patients qualified as presenting with obsessive compulsive personality disorders, about 11% with avoidant personality disorders. When they looked at their temperament, keratoconus patients had significantly higher scores on depressive, cyclothymic, and irritable temperament scales. Keratoconus patients also scored significantly higher on the neuroticism scale. Higher scores on subscale parameters such as somatization, obsessive compulsiveness, interpersonal sensitivity, hostility, and psychotism was also found. Now, one thing I want to say, as you're listening to this, it almost feels like we're targeting keratoconus patients to be this way. I really want to stress this point that these are tools. This is not meant to be a prejudice to our keratoconus patients. You don't walk into a room thinking of these things to be prejudiced against them, but we're going to use these tools, use these findings to help us better understand how we can present not only the diagnosis, but the treatment options and how we can better ourselves. And that's how I see this. I see this as a tool, not as prejudice. And that's one thing I really want to kind of stress, because when I read all this and when I've been looking at this and kind of incorporating it, it's hard not to think of every patient that way, but we need to take a step back and look again at the big picture. So, a couple of discussion points from all this. Let's take a look at eye rubbing, right? Eye rubbing is a significant risk factor. It's a behavior that's linked to the externalization of emotional stress, and it's a compulsive behavior. That's starting to make sense when you look at the personality traits, when you look at their mechanism, right, of how they deal with stress. Second point, inflammatory versus non-inflammatory. I feel like I've been reading more and more about this with keratoconus lately, and there has been some research, and there is research that's being worked on it. When you look at it, there has been research that's found that there's increased cytokines in keratoconus buttons. There's an upregulation of pro-inflammatory factors. So, as most definitions are that keratoconus is non-inflammatory, is there an inflammatory factor in there? So, let's go on to treatment options. Our treatment options, it's not a one-size-fit-all answer for these patients. It really isn't. There are multiple factors at play here. There's age, there's time of life, financials, length of treatment. Does this patient have a support system or not, right? So let's look at another factor here, the quality of life factor. How does this diagnosis affect the patient? What's our patient's priority? And how do we come up with a personalized management plan for our patients? So, quality of life testing. Why do we test it? We test this because a lot of our keratoconus patients, it's an early onset, it's progressive, and it's chronic. There's frequent changes, and the treatment might have to change as you're kind of going on. There's serious vision impairment that can happen from this, and this is why we're testing their quality of life. How do we test it? It's hard. It's not objective, right? You can't just go to the topographer and look at a difference map, right? Or you can't just ask the topographer to scan it and it's not going to tell you an answer. Even our refractions are hard, as I have that written there. So there's questionnaires, and we use questionnaires to really help us with that. There's keratoconus specific questionnaires, there's sometimes personality ones, there's mental health ones. As I said earlier, the most common one that we use is probably the National Eye Institute Visual Function Questionnaire. So let's take a look at some of the questions that are asked. I think it's important for us to see what is being asked because it starts to make us think, all right, what is important to our patient? So some of the questions that are asked are, how hard is it, or how much time do you worry about your eyesight? How much pain and discomfort is in and around your eyes? How hard is it finding something on a crowded shelf? How hard is it going up and down the steps in dim lighting? How hard is it to see people's reactions to things that you say? Something that we take so granted, I think. How hard is it to drive? Do you accomplish less due to your vision? And then control over what you do. So they ask that in the quality of life type of testing. Results from the study show that keratoconus patients that wore contact lenses had a better score than non-wearers, worse scores in women than men. Patients with poorer visual acuity, steeper keratometry reading, and lower central corneal thickness scored worse. And patients who had corneal transplant scored higher in the quality of life questionnaire. Now, when you look at this retrospective study here that was done, it evaluated the impact of vision impairment in keratoconus patients. And the results from this was that patients who had not undergone corneal cross-linking had worse mean activity limitations than cross-linking. So you can see how cross-linking can not only help from the financial side that we talked about and from a progressive side, but also from a quality of life perspective for our patients. Other treatments that help improve quality of life, you can see here, is scleral lenses. The NEI Visual Function Questionnaire was used for this, and it found that there was an improvement in both visual functioning and socio-emotional scales after scleral lens fitting. Intrastromal corneal ring implants also helped improve psychosocial criteria and decrease visual dependence on others after the surgery. Corneal transplants have also proven to improve quality of life scores and visual quality after corneal transplant in one eye. So what do we do with all this information, right? We have all this information for us. How do we make the best decision for our patient? What factors are we looking at to help these patients? And honestly, what's the goal here? How long will it take to achieve that goal for not just us, but also for our patient? So as we do this and as we go through this, I'll tell you a little bit about kind of my journey. As I said, 10 years ago, when I started seeing keratoconus patients, for me, I didn't really think of all of this. They weren't things that I was thinking about. I wasn't thinking about how relatable I can be, how I can understand their journey or what they've gone through. For me, it was fitting specialty contact lenses. It was diagnosing them. Did I get the right diagnosis? All right, what am I doing next? How can I wow my patient? I think that question has really changed to how can I help my patient, right? So, how do we, as an eye care provider, apply all this information that we just learned about the background behind our keratoconus patients? How do we use that to help them properly? Some of the things that I have here and kind of the role of the eye care provider, one of the things I'll say is providing and taking that extra time with these patients. I just 2 years ago opened a cold start practice. I really am very blessed with a lot of colleagues sending some of their keratoconus patients and seeing them. I'm humbled by my keratoconus patients that trust me. One thing I will say, when we see new patients in the office, we take extra time. I have at least 90 minutes that are dedicated to seeing these patients. Kind of, I will say the diagnosing part is the easy part. Sometimes it's the easier part. It's the going over all the information, showing them the scans, showing them what we're looking at, and taking that extra time with those patients, um, going over treatment options with them. A lot of times I ask if the patient is on the younger side to bring a parent or someone that they trust with them, so there's someone in the room with them. I always like requesting previous records. Looking at the previous records really helps you understand their progression, understand their journey of where they're coming from. Was it that they were saying that their vision was changing? Did they get new glasses? Are they frustrated? Have they tried contact lenses in the past? What has been their journey up until now? What's the timeline? I also like looking at their symptoms because when you look at the HPIs and the history that the doctors are taking, you get to hear a lot about what the patient feels, right? Setting expectations. That's a tough one because I feel like this is where I have to be pretty stern about it. All right. This is where we are. You have to come back for your follow ups, or you have to go see this referral doctor. This is not a choice. Kind of really kind of setting that expectations with patients, setting the expectation that it's not a one time deal. You're not here. I'm not going to fix you, and I'm not going to see you back in just a year. You're going to come back for your follow ups. And that also leads to explaining that timeline, that there'll be multiple visits. Discussing treatment options is always a tough one. I feel like, once again, as I explained, there's so many factors at play. It's interesting because right now, as I'm seeing keratoconus new patients, and you see that they have progression, talking to them maybe about referring them for corneal collagen cross-linking, holidays are coming up, right? Or finals are coming up. Is this the right time for you to go next week for a referral? Or is this the right time for you to have surgery? And every case is different. How much is your progression? Where are you in life? What's going on, right? So, kind of understanding the patient all goes back to taking that extra time with the patients. Consent forms. So, I will tell you, after working in the refractive surgery space, consent forms are scary. There's even death that's written on the consent form. So when you as a patient, you're reading that, it's a lot to process. This can have a lot of psychological implications. So when I am making a referral for cross-linking, or if one of my keratoconus patients is going in for a corneal transplant, I talk to them about the consent forms. I give them a heads up. Talk to your surgeon about the consent form. Read them. If you have questions, ask the surgeon. Ask the surgical coordinator, and you can always come back and you can ask me questions. Just leave a message at the office and I will give you a call back. Educated refractions. And when I say educated refractions, I usually always start off my refractions with keratoconus patients by saying, I know you don't like this. I can tell from the times that you've done this, this is not very helpful, right? But let's try this. I try going slower, maybe making some bigger movements, not your typical refraction that you're doing, maybe kind of going out of the box. I'm sure those of you that have seen keratoconus patients or see them, you have your technique of doing it, and that's kind of the educated refraction part to it. Giving written notes and educational materials that patients can walk out with, I think goes a long way. That having something in their hand, physically having something instead of just telling them where to go. And then finally, a support system. Having a good support system and knowing that the patient has a good support system is really important, at least from a perspective of an eye care provider, because you want to know there will be someone that goes with them to their surgical consult. There is someone that's at home that can help them if they need that help. Some of our patients need help with putting in their contact lenses, taking them out. Some of them need help understanding what the surgical process is, right? So making sure of that. I'll tell you an example. I had a patient just probably 6 months ago. She came, she's 21 years old. She came to the office by herself, first time being diagnosed. I went over as much as I could. You could tell she was scared. What I told her was, here, let's set up a time tonight. Let's do a Zoom call at 7 o'clock. How about you have your parents on the Zoom call? Let me answer questions. Let me explain to them what's going on. I will tell you, they were probably the most appreciative family I have. Lo and behold, mom comes with the daughter to her cross-linking post-op appointments, and mom tells me, I've always thought that my left eye is a little blurry. We do a tomography scan on her, and it's a form for us keratoconus patient. So it's interesting to kind of see how having that support system has helped, because now both mom and daughter wear scleral lenses. They both have little techniques. They've taught me different things that they've done at home, experiments of how, like, they've set up little stations for insertion removal, and you just realize that you become a part of their family. So what's our roadmap here? Phase one, education, right? In office and materials that they can take home and review. Two, treatment-based plans for patients based off of their needs and capabilities. Three, referrals. I will say I spend probably way too much time writing letters to my referring doctor, the person that referred the patient, and also to the doctors that I'm referring the patients to, so that they can see everything. They have all the notes. It doesn't take time to establish that there's progression. I kind of take all that time so that that's not a holdup. And then finally reviewing that long-term outlook, letting the patient know, understanding it, that they're coming back for multiple visits. What do you need more from me? Having follow-up appointments. When it comes to resources, it's kind of fun. You can get really creative. I'm sure a lot of us have stories of what you do that's a little different. And honestly, please take my email down at the end and share your stories, because I'm always willing to learn of how I can change things. First, starting off with educational materials, in-office pamphlets. I cannot tell you, like, National Keratoconus Foundation is a nonprofit. They provide amazing resources, not just the pamphlet that I can give to the patient, but also as a website. So I love giving that website out, because that's where patients can find a support system. They can find blogs, they can look up these treatment options. And it's not Google that tells me that I, should have died from a migraine 4 weeks ago. So it's a vetted website. It is a nonprofit. I love giving that as a resource. Verbal references of where they can go and what they can do. Demonstrating to patients what they're going to see, eye models, drawings, and also when it comes to referral doctors, writing everything down, making sure that they have the doctor's name so they know their phone number, their address, and also we end up texting them when their appointment is, where they're going, and all that information for them too. So, some examples of this. When it comes to the resources, I absolutely love this model. When I received this model, I felt like it was like the model that I got when I was in school, and just thinking about, oh my gosh, when I practice, I will take this model and use it on every patient. That's kind of how I feel about this. This sits right on my desk. This model is a gift from an FDA, the only FDA approved manufacturer of corneal cross-linking, and they have done a phenomenal job of creating this model that really explains a lot. First, it helps me explain where the cornea is, right? The windshield, that's the part that's affected, so they can see that in perspective to the rest of the eyes. Then you have these small little handheld models that you can put up to your eyes, and you can really test out to see the distortions or the glare or the starburst depending on the type of keratoconus you have. It's cool to show the little discs that have the topography kind of map on there, so that it's been fun kind of to show the patient their map and show them the type of, like, oh, look, this is how it is. You can hold this eye model piece to see what kind of distortions you're seeing. Now, more so than the keratoconus patient, I think this is beneficial for whoever's with them, their spouse, family member, significant other, whoever's in the room with them. I think it's neat for them to see it, because they get to see what that patient might be experiencing, right? So this model is great in not only educating, but also becomes fun in explaining. here, I have a video here, and this video kind of is going over, and I was so excited to show one of my patients the eye model, and he's someone who has been diagnosed, he's someone who has, been treated and seen me for a while. So it's kind of cool to show him the model, and you can see him trying to look through the different models here, different types of keratoconus, and kind of see, oh wait, this is like what I see a little bit. So I like kind of going over this. This is again with taking that time and then showing the topographies. Thank you to Dr. Chang. I appreciate so much that you have not only done in mentoring me, but also for these images. I have these images printed out and laminated. Again, this I think is more so for the family members. This is for more the person that comes with so that they can see basically what that patient is undergoing with their vision. A lot of times it's also great for the patient because you can see, all right, we're in the mild stages. This is what you may be seeing when it comes to halo and glare. This is what you may be seeing with reading. But if this progresses, this is what can happen. So in a way that, isn't scary to the patient, you can kind of explain that and show them this so they understand also the severity of it. These are some more images. You have halo and distortions. You have halo and starburst here. I think these are great images. I believe these are images of Philadelphia. So anybody who's from the Philadelphia area, you can see kind of like the city from here, and you can see as you see the halo and distortions and the starbursts. Other resources. So if you're like Dr. Komornik and myself, we like to draw things on the back of our encounter forms or on the back of paper that we have. And you can see his staff kind of making fun of him here for his birthday. They gifted him a little blanket that basically goes over all his drawings. And there are some drawings that are about keratoconus or specialty lenses. So you can see the light rays going in and how he explains scatter and kind of how specialty lenses can help with that scatter. So it's cool that you can take time. Drawing really helps a patient understand that. Also, this is in the middle is the keratoconus patient guide. It really does go over keratoconus. It goes over treatment options. It has the website. It has links so that patients can find support and others that can help. There's a blog also with them. Some of our colleagues have written blogs on there. They have a podcast also that patients can listen to. It can be also for us when we're kind of listening at newer treatment options that are there. And then finally, looking at testing, you can see here, I have a patient that I'm testing, and I like going over the testing with them. So I try to do the testing as much as I can so I can show them exactly what we're doing, what changes we may make, or where things are. Have they progressed? Have they not progressed with their keratoconus? And I think patients truly understand that, really appreciate that, taking the time to go over it. So kind of wrapping things up and really kind of bringing it together about how we can take this information. Again, I really do want to say, I don't want you to use this as prejudice against keratoconus patients as, oh my gosh, these patients are maybe difficult or there's so much more to it. I want you to use it as a tool to understand your patients a little better and how you can change small things like how you present or how you diagnose for patients, or even talking to patients about bringing a support system into the office so that you have more people that can help them. Looking at the patient as a whole and not just looking at the patient as just a set of eyes, really helping manage their expectations, going over again that this may be something that, yes, maybe we can just help you with a pair of glasses or specialty lenses. Or this is something that we need to do a little bit more of. Let's slow the progression. Or we're at a point where we need to talk about corneal transplant, right? Kind of going over that because you are that central person for that patient. You may be the only one that's really taking that time to go over it. So make sure that you're educating them, handling their expectations, reassuring the patients. And this outlook can really truly be looked at for many chronic progressive diseases, not just keratoconus. The only difference is, as we talked about in the beginning, keratoconus is something that happens at a younger age. So you're dealing with a very different population that's not used to hearing about something that's going to impact them for the rest of their life.